First of all, I would like to inform you that neither Bettina Bessler nor Matthias Friedrich are able to attend today's meeting, and I was asked to be the moderator. My name is Anna Fehrmann. I'm a radiologist and currently a resident at the University Hospital of Cologne in Germany, and I'm part of Bettina's working group. Shortly a reminder of the rules and procedures of this journal club. The meeting is being recorded. We are going to have 2 papers presented today. The presentation of each paper should take roughly 10 minutes, allowing for some additional time for discussion. And you are all very welcome to ask questions and participate in the discussion. You can either unmute yourself during the discussion or write your questions in the chat, and I will ask them on your behalf. Today's topic is myocardial strain. The first paper is about strain and differentiation of different forms of myocardial hypertrophy. And the other paper is about outcome prediction based on strain measurements. It's a huge pleasure for me to welcome the 2 presenting authors today. First, Sorin from the Department of Cardiology in Weinheim, Germany. And second, Chunna from St. Francis Hospital and Heart Center in New York, USA, and the Department of Cardiology in Hangzhou, China. So we'll start with the first paper of today's journal club. The title is Multi-Parametric Assessment of Left Ventricular Hypertrophy using late gadolinium enhancement, T1 mapping, and strain-encoded cardiovascular magnetic resonance. And I would ask Sorin to share his screen and walk us through the publication.
Thank you very much. First of all, thank you very much for this invitation. I'm really honored, and on behalf of our working group, we are really honored to be able to present. First, we are really happy that the paper was accepted for publication in JCMR, and then now that we are able to present our results in this journal club. So this was a team effort, and I would also like to take the opportunity to thank all my colleagues that worked in this, especially in this project, but there were also other projects involving fast sank. So left ventricular, we start with the beginning. Left ventricular hypertrophy is a relatively common finding, non-invasive finding in cardiology practice. And it can be seen as an adaptive process in athletes. It can be seen as a result of increased afterload in patients with hypertensive heart disease. It can be an expression of myocyte hypertrophy and disarray in patients with hypertrophic cardiomyopathy. And increased wall thickness is not per se a left ventricular hypertrophy, but an increased wall thickness can also be seen in patients with cardiac amyloidosis. Of course, there are also other clinical scenarios such as aortic stenosis or Fabry disease, which associate left ventricular hypertrophy or increased wall thickness. It is really important in all these clinical scenarios to establish a differential diagnosis, because each of these either adaptive process or maladaptive process has is important for establishing diagnosis, as each of these diseases has a certain therapeutic approach. In this, fast sank is a method that can be used in cardiac MRI for extracting data related to circumferential and longitudinal strain. It was already validated in several studies, and we previously showed an excellent inter-observer, intra-observer, and inter-study variability in these patients. Herein, we sought to evaluate the ability of fast sank derived left ventricular strain to distinguish between different forms of left ventricular hypertrophy in competitive athletes, patients with hypertensive heart disease, patients with hypertrophic cardiomyopathy, and cardiac amyloidosis. We also wanted to look at the ability of normal myocardium. I will immediately show you what normal myocardium, how we defined it, by fast sank, and to achieve this differential diagnosis and to compare with that of left ventricular ejection fraction, T1 mapping, values from T1 mapping, left ventricular mass index, and late gadolinium enhancement. We analyzed, the study took place in Hamburg at Marian Hospital between 2017 and 2019. We analyzed a total of 314 patients, as well as 22 competitive athletes and 33 healthy subjects. We performed left ventricular hypertrophy was defined as increased wall thickness in any segment above 12 millimeter. We performed a standard cardiac MRI protocol with normal volumetry morphology, and as well as the acquisition of T1 mapping and the acquisition of late gadolinium enhancement. To that, we also did an acquisition of single fast senk on a single heartbeat myocardial strain. Maybe I will show you for those who are not familiar. Here, exactly. So this is the acquisition for a single heartbeat fast senk. Basically, there are 3 long axes and 3 short axes. A little bit counterintuitive because the acquisition is perpendicular to the plane. From long axis, we derived the circumferential strain, and from short axis, we derived the longitudinal strain. I will go back to the paper now, basically. So we also looked at the late gadolinium enhancement. We looked also, we derived a semi-quantitative score depending on segments with who exhibited late gadolinium enhancement, as well as at the distribution of late gadolinium enhancement, either intramyocardial or diffuse late gadolinium enhancement. We also derived a parameter called normal myocardium, as you can see here, and was defined as segments who exhibited a normal circumferential or longitudinal strain. We derived from previous study the value from normal as smaller than minus 17%. This is the data from previous study, and because we are analyzing 21 segments circumferential and 60 segments longitudinal, this was divided by 37. When we look at the results, in total, we had 369 individuals. We had 41 patients with amyloidosis, 45 patients with hypertrophic cardiomyopathy, 228 patients with hypertensive heart disease, 22 athletes, and 33 healthy subjects. I will just move to the table, and here you can see the data. Looking at the demographic data, we've seen that patients with amyloidosis and hypertensive heart disease were elder than patients with hypertrophic cardiomyopathy, and as well as with athletes and healthy subjects. Athletes exhibited the highest value for left ventricular and diastolic volume, which is to expect it. It is known that this is a adaptation process in athletes. The left ventricular ejection fraction was similar between the groups, except patients with amyloidosis, who showed a niedriger but still in the normal range left ventricular ejection fractions. The highest level of hypertrophy were seen in patients with hypertrophic cardiomyopathy and amyloidosis, and this was also seen by the left ventricular mass index, which showed the highest level of shows the highest value for left ventricular mass. Maybe if we move to the figures, it's easier here to see. This is the same data but presented in figures. Here you can see the left ventricular ejection fraction. The mass index increases from normal and athletes to patients with amyloidosis. The T1 values were significantly higher only in patients with amyloidosis. There was not a significant difference between all other 4 groups. And a typical LG score was also highest in patients with amyloidosis, but was also different in patients with hypertrophic cardiomyopathy versus hypertensive heart disease and versus amyloidosis. The values for longitudinal strain, and I'm referring here not to the minus values, I'm referring to the absolute values, decreased from normals and athletes to patients with hypertensive heart disease, further to patients with hypertrophic cardiomyopathy, and then the lowest values were seen in absolute values were seen in patients with amyloidosis. The same was seen with the parameter normal myocardium, which was undifferentiated, which didn't see any difference, or that didn't pick up any differences between normals and patients with and athletes. And then further decrease in patients with hypertensive heart disease, then further with patients with hypertrophic cardiomyopathy, and then the lowest values were seen in patients with amyloidosis. And then we wanted to look at patients with mild moderate hypertrophy, because in clinical practice you always have those patients that have like a septum of 12-13 millimeters, and it's I'm a bit unclear what is the underlying cause for these patients, and we wanted to check if these parameters in CMR can help differentiate these patients. And basically we looked at patients with left ventricular wall thickness between 11 and 15 millimeters, and we had 8 athletes, 111 patients with hypertensive heart disease, 14 patients with hypertrophic cardiomyopathy, and 13 patients with cardiac amyloidosis. In this patient, there was no difference in left ventricular ejection fraction. There was also was only a difference between T1 values only between patients with amyloidosis and all other patients. On the other hand, normal myocardium could differentiate between hypertensive heart disease and patients and athletes, and also hypertensive heart disease and patients with hypertrophic cardiomyopathy, but couldn't differentiate between hypertrophic cardiomyopathy and amyloidosis. On the other hand, the atypical late gadolinium enhancement score was able to differentiate between the latter two groups, amyloidosis and hypertrophic cardiomyopathy. When we grouped the patients and we performed ROC analysis between these patients, we've seen that normal myocardium was excellent in differentiating between athletes and hypertrophic cardiomyopathy, also really important in differentiating between athletes and hypertensive heart disease. On the other hand, atypical late enhancement score was very useful in differentiating between patients with hypertrophic cardiomyopathy and amyloidosis, as well as between patients with hypertensive heart disease and hypertrophic cardiomyopathy. A combination between atypical late enhancement and atypical late enhancement and normal myocardium was excellent in differentiating almost all these 4 groups separately between hypertrophic cardiomyopathy and hypertensive heart disease and hypertrophic cardiomyopathy, as well as athletes and hypertrophic cardiomyopathy in the entire cohort, and also when only focusing on patients with mild moderate hypertrophy. Also, the combination of left ventricular late enhancement, late gadolinium enhancement score and patterns, as well as normal myocardium, allowed for the precise differentiation between the underlying pathologies. When, in conclusion, so we are going here to the discussion segments. Here I can show you also 5 examples with fast sync analysis between a normal subject, just the color coding, blue is good, yellow is bad. So just to have an idea of how the color coding works here. Here you have a normal subjects and an athlete's heart here. And you see that the ejection fraction still is normal in hypertensive heart disease, but these patients exhibit already a reduced strain value, which is further reduced in patients with hypertrophic cardiomyopathy, with the lowest values to be seen in patients with cardiac amyloidosis. So in conclusions, when we move, okay, here. Of course, the study had some limitation. Our cohort was extremely heterogeneous in respect to demographic data. In addition, ECG data were not systemically analyzed, and age and sex matching was not performed, which can be a possible limitations. However, fast-derived myocardial strain, based on our data, is we can say that it's a valuable tool for the characterization of patients exhibiting left ventricular hypertrophy, and can be used together with atypical late enhancement to help establishing an etiological diagnosis in patients with left ventricular hypertrophy, and especially in patients with mild moderate hypertrophy of unclear etiology. And I think I'm 4 minutes above my time. Thank you very much. And again, thank you very much to all the people who worked at this study. I'm really, really grateful, and I'm really grateful that I'm able to present this data now.
Thank you very much for this very interesting study on a very important topic. As we all know, the differentiation of the underlying cause for left ventricular hypertrophy is clinically challenging, but highly important because of different therapeutical approaches. Mm-hmm. There is already one question in the chat. Is it common that 10% of athletes have LGE?
So this is a well-known fact. Also, our athletes exhibited LGE. I will look at the table. So this is the atypical. So this is 14 pre-athletes. Its previous study have shown the same thing. so until now, the clinical relevance of this LG is unknown. I want to also to point out the fact that although 3 athletes exhibited LGE in our cohort, there was no difference in normal myocardium and no difference in global longitudinal or either circumferential strain between control group, between healthy individuals and athletes. But it's true, it's a well-known previous study already showed that some athletes exhibit late gadolinium enhancements really more often at the insertion points of the right ventricle. It's an intramyocardial, atypical late enhancement. If this is clinical relevant until now is unclear.
Okay, thank you.
Okay.
If there are any other questions, you can also unmute yourself and ask them directly in the discussion. In the chat, until now, there's not much more coming. And due to time constraints, we also have to move on the next paper. The paper is titled The Association of Reduced Left Ventricular Strains with Increased Extracellular Volume and the Collective Impact on Clinical Outcomes. I think it's now Jane Cow. If you would please share your screen. Thank you.
Sorry. Can you see my shared screen now?
Yes, we can.
Okay, thank you so much. It's our great pleasure to share our work with you, and I represent our team to have this great honor to share this work with you. The Association of Reduced Left Ventricular Strain with Increased Extracellular Volume and their collective impact on clinical outcome. It is well established that increase the myocardial fibrosis and reduce longitudinal strain associated with adverse clinical outcome. In this study, we aim to investigate the relationship between the two. In addition, we wanted to expand the strain evaluation by including circumferential or radial strain. Lastly, we sought to examine the collective impact of strain and tissue properties on clinical outcome risk. This is a prospective study that recruited patients referred for clinical CMR. Written consents were obtained from all. There were 259 patients and 21 normal controls included. So now let's look at patient or participants' characteristics in table 1. The average age of the patients were 56 years. LVEF was 51%, with 36% having EF below 50%. LGE was found in 48%. Here's a breakdown of the CMR diagnosis here. So the largest single group was dilated cardiomyopathy of 31%. The others were relatively evenly distributed of a little over 10% in each of the categories, including ischemic, hypertrophic, infiltrative, and a valvular disease. The prevalence of myocarditis was 7%. The other myocardial disease group included those with regional or global hypertrophy, but they did not fit into any disease categories or having evidence of a non-infarct LGE pattern. On average, all 3 strain parameters were reduced in patients compared with controls. Interestingly, the T1 parameters on average, whether it's ECV native T1 or post-contrast T1, were not significantly different from the controls here, as we see here. So now let's look at examples of normal controls on the top 2 panels and then a patient on the lower panel. The normal control has normal value of native T1 post-contrast ECV, and here's a normal pattern of longitudinal, circumferential, or radial strings. Here's a patient with markedly increased T1 value of 1120, and this is ECV of 44%. Here we see markedly reduced longitudinal strain and also moderate reduced circumferential and radial strain. So now let's move on to look at the relationship of strain and T1 parameters in figure 2. Let's focus on the left panel first. This is the relationship of longitudinal strain with T1 parameter. The y-axis is the longitudinal strain, and then the x-axis is T1 parameter. So let's focus on the left top panel, which is the ECV. So here we see that the longitudinal strain remained relatively normal in a flat line until the ECV reached 2 standard deviation above the normal. There is a clear deflection point above which there was a graded decrease of longitudinal strain with increase of ECV. I just want you to bear in mind that longitudinal strain is a negative value, therefore the less negative that is, the lower the value that is. Now, here is this middle panel is native T1, where we see the similar relationship, although the deflection point is at 1 standard deviation. Last one is post-contrast T1, similar relationship, but the deflection point is at 2 standard deviation below the normal. Now, the rest of the panels are the relationship of circumferential strain in the middle panel and the radial strain in the last panel. They all show similar relationship as what we have discussed in the longitudinal strain. I noted last night that the y-axis should be positive value. I apologize, we were alarmed at the publisher. So then we say, well, we observe this phenomenon in a mixed large group. What about in a relatively homogeneous disease group? So next we look at our largest single group diagnosis, which is a dilated cardiomyopathy. We actually observe a similar relationship, although as we know, the ECV and native T1 tend to be not as severely abnormal as other disease, such as amyloidosis. So we see a relatively small change, but still the trend is there. Although in the post T1 analysis, the relationship not as strong. So next we look at the outcome data. We follow those patients on average of 31 months, but some we follow as long as 9 years. During this period, 41 events occurred. Of those, 37 were hospitalized to heart failure and 4 were death. So first, let's examine the impact of strain on clinical outcomes. This is a dichotomized examination. Let's focus on the top panel. We observed that reduced strain, whether it was longitudinal on the left, circumferential in the middle, or radial on the far right, was associated with significantly reduced event-free survival if the strain value was reduced. Next, we stratified the higher or lower strain with normal or abnormally increased ECV, as shown in the figures in the lower panel. Those with both reduced strain and increased ECV in brown had the worst event-free survival. Among those with increased ECV but higher strain, shown in green line, also had reduced event-free survival, but to lesser extent. Interestingly, those with normal ECV, whether strain with higher or lower, share a similarly favorable event-free survival on the top. So in table 2, where we perform Cox proportional hazard analyses. In the adjusted model, adjusting for age, gender, hypertension, diabetes, LGE patterns, there was more than twofold increase. Let's look at the right panel, which is the adjusted results. We see at least twofold increase in risk associated with reduced longitudinal, radial, and circumferential strain. Using 2 standard deviation above normal, there was threefold and twofold increase of outcome risk for ECV and post-contrast T1 value respectively, but not for native T1. In the stratified analysis, based on high or low strain and normal or abnormal ECV, there was a numerical graded increase in outcome risk. In the adjusted model, the last stratum where strain was lower and ECV was abnormal increase, there was 6-fold increase in the outcome risk in the adjusted model. So in conclusion, there's a dose-response relationship between T1 parameter and impairment of longitudinal circumferential radial strain. But I want to emphasize that such relationship only exists when T1 parameters or myocardial tissue properties were abnormal. We confirmed prior observation that reduced strain is associated with adverse outcome risk. However, we noted that the outcome risk in association with reduced strain occurs only when ECV is increased and not when ECV is normal. Those with both increased ECV and reduced strain have the worst outcome. Now, our findings certainly highlight the intrinsic link between the tissue property alteration and the myocardial mechanic impairment. They also demonstrate an essential role of tissue characterization in risk stratification among those with reduced strain. So here I end my talk, but I want to thank my team for their significant contribution and also want to thank CMR for inviting us to present our work. Thank you all for attending.
Thank you very much. Great work. Are there already any questions from the people that are listening? If you want, you can just unmute yourself. If not, I would ask a question myself.
Yeah, I have a question. Can you hear me?
Okay, yeah.
Hi, Jane. Thank you for this great presentation. So for the borderline cases, where you say that there's a break in the strain, did you observe any regional motional abnormalities?
That's a very good question. In this particular study, we didn't actually break down into the different categories, whether they have normal, regional versus regional abnormality versus diffuse wall motion abnormality. But that is an excellent question. We are looking at another separate study, but we haven't finished. We want to actually address the very question that you asked, an excellent question. We were wondering about that ourselves too.
Thank you.
So, any more questions? Maybe also for Sorin from the first paper presentation. You have the opportunity now to ask them in the chat or just unmuting yourself.
So I'm still there.
Maybe then just a short question for myself. In your institution, do you implement fast sync in your clinical routine, or is it still just for research?
It's so somewhere in between, basically.
Okay.
So it's somewhere in between. We basically have two large groups of protocols. We have ischemia protocol and RUE, or the protocol without ischemia, and we acquire automatically in those that have that don't have the ischemia protocol. So in those that just have a regular CMR, we acquire the fast sync data, but we analyze it clinically only if questions like this, if myocarditis or left ventricular hypertrophy, I'm not sure where's the diagnosis, and so on and so forth. So it's somewhere, and by patients, in patients with where we have an ischemia protocol, only if there is, you can also have two questions, like, does the patient have ischemia, or what's the cause of the left ventricular hypertrophy? So you can, the patient is allowed to have two problems. So we also, but a standard ischemia protocol doesn't, we don't acquire it.
So in the chat, I don't see any more questions. I mean, we reached the 30 minutes, so if there's nothing more from the listeners, there's also the possibility to ask you directly, probably to write you an email if there's still emails.
Definitely.
And so I would thank you. I would thank you both, Sorin, Juska, and Jane Cow, for the wonderful presentations. And thank you everyone for joining. You will get further information on the next journal club per email, and see you next time then.
Thank you. Bye everybody.
Bye-bye.